Hello, I'm Nick Battersby, a surgical registrar from Basingstoke in the UK, and as part of the ESCP's initiative to highlight the consequences of treatment after colorectal cancer, I've been asked to talk about two consent aids that highlight the risk of bowel dysfunction after an anterior resection. The first is a simple pictogram consent aid, and the second is a more personalized online tool. We know that bowel dysfunction is a problem after an anterior resection, and that this can have an adverse effect on quality of life. For example, in this DCR study, we found that looking at nearly 500 patients with a median time of 5 years after surgery, almost 41% reported a major impairment in their quality of life. And when we looked at the multivariate analysis to establish the risk factors for this, essentially the risk factors were the height of the tumour and the use of radiotherapy. And that multivariate analysis was converted to a simple pictogram. We found that if you're in that group who have an upper rectal cancer and you have no radiotherapy, then about a fifth of the patients will have no impact in their quality of life or bowel-related quality of life impairment, whereas a third will still find they have a major impairment to their quality of life. On the other hand, if you have a low rectal cancer and radiotherapy, only about 7% of patients will find that there's no impairment to their quality of life, and the likelihood is that the majority of patients in this group will have major impairment to their bowel-related quality of life. Now, when consenting patients, often we find that this is enough just to show this pictogram, and that gets the message across to the patients when there's a lot of other factors that they really need to be taking on board this early on in the cancer consent process. But inevitably, if the patient does think they're going to have major impairment to their quality of life, they want to know exactly what that means. And as well as the LARS score problems that we're familiar with, so major LARS will cause clustering, urgency and frequency in particular. In terms of the major impacts on quality of life, there's really a triad of symptoms using the EORTC30, and that is insomnia, fatigue and bowel dysfunction, either as diarrhea or constipation. And on this particular PROM, there's more than a 20-point difference for these three factors, so that would be regarded as a major clinically important difference. When we then consider the functional element of the scoring domains, then again there's a major difference, more than 20 points, between the group that report no impairment to quality of life and major impairment to quality of life in terms of global quality of life, role, which essentially means work and responsibility impact, as well as their social functioning. Pain and financial consequences are also important. This may be sufficient in terms of the patient discussion, but some patients will want to have a more tailored discussion, and if that's the case, then we've developed the POLAR score. So this is the preoperative prediction of their low anterior resection score, and this is a score that we developed and externally validated, that was published in Gut. We used 422 UK patients to develop the score and over 700 patients to then validate this, and they were Danish patients. We used something called LASSO, which is a complex regression method, and used tripod, which is the established method for developing clinical models. And to give you an example of how this works, so in this scenario we have a 70-year-old male. You can see they've got an upper rectal cancer at 14 centimeters from the anal verge, no radiotherapy, but there is a plan to offer TME. So if you click on the POLARS score, then you'll find that you can then input these values. So age 70, a male, TME, height 14 centimeters from the anal verge, no use of a stoma, no use of radiotherapy. You calculate that, you find it's minor Lars. So that should imply that this will have very little in the way of impact to their quality of life. On the other hand, in a separate scenario, you have a 65-year-old male. Here the tumour is 4 centimeters from the anal verge. There are some lymph nodes which may be of some significance, and so the decision is to offer radiotherapy, TME and a defunctioning ileostomy. And when that data is inputted into the POLARS score, the predicted Lars score is 32, so you'd anticipate a major impairment to their bowel-related quality of life. On the other hand, if we look at the current ESMO guidelines and decide not to offer radiotherapy in this context, then the predicted score when inputted will be 28, so minor Lars, so a significant improvement in terms of the bowel-related quality of life impairment. So we anticipate that this will have some important clinical relevance, particularly in terms of highlighting to patients what their risk of postoperative bowel dysfunction is likely to be. We think it may inform some multidisciplinary decisions, but particularly that ability to tailor the patient consent. We'll find that the high-risk group should then have a better understanding of what the consequences of bowel dysfunction are likely to be, and a greater awareness of a colostomy as one of the possible options, although I don't think this is necessarily the only option, and there are other methods to try to optimize bowel function. And finally, it may be useful in clinical trials to identify this high-risk group so that we can try to optimize their function. So please visit the Pelican website here at this link below and feel free to use the score. We hope it's of relevance and use in your clinical practice. Thank you very much.